Dr. Mike LeNoir, and this is the Wellness Watch. Welcome to today's edition of the Welcome Watch. I'm your host, Dr. Mike LeNoir. Our special guest today is Dr. Charles Wyndon. Dr. Charles Wyndon is a neurologist. I think for most of us, you may have never encountered a neurologist. So we're going to let you tell them a little bit about yourself. Dr. Wyndon, tell us how you got, what your journey to neurology was like.
Sure. So first and foremost, I just want to thank you, Dr. Mike, for allowing me to be on the podcast this evening. Very much appreciated. So my journey into neurology actually started before I even went off to medical school. In between graduating from college and going to medical school, I actually moved home for a period of time, and I was a caretaker. I helped my father take care of his mother who passed away from Alzheimer's disease. She actually passed away during the pandemic. And that experience as a caretaker and witnessing firsthand somebody who had Alzheimer's and dementia, that fundamentally changed what I thought I was going to do with my life and really inspired me to pursue neurology as a career.
So tell us a little bit about your training. When you become a neurologist, what is it you have to do? Where'd you go?
Sure. So in terms of training, in order to get to the point where you're a physician, you have to do 4 years of college, then you have to do 4 years of medical school as well. After that, you do additional training. So typically most neurologists will do a year of what's called an internship, where you have a lot of experience in internal medicine. And then you spend 3 years doing a neurology residency. And so during that residency, that's when you're really exposed to the nitty-gritty of neurological care. And that's where you really hone a lot of your skills. There are some neurologists, including myself, who will pursue additional training thereafter in what is called a fellowship. Fellowship is typically dedicated training within a subspecialty of neurology. So there are some neurologists, for example, who like to specialize in stroke. There are some neurologists who like to specialize in epilepsy or seizures. There's some neurologists like myself who like to specialize in what's called behavioral neurology. So we really focus on individuals who have Alzheimer's, dementia, other conditions that cause changes in behavior and memory. And so that's typically anywhere from 1 to 3 years, depending on what specialty you go into. I did a 2-year fellowship.
Tell us a little bit about the UCSF Aging and Memory Center.
Sure. So our Memory and Aging Center is located in San Francisco in the Mission Bay area. We've been around actually for 22 years, give or take. We've been here for quite a period of time. It's a very large center. We've grown from a very small group of individuals to, I believe, over 300 different staff members. We have a beautiful new campus down on 4th Street. It's right next to the Chase Center, but we're really a team of individuals composed of physicians, social workers, nurses, research coordinators, other folks as well, additional staff folks. We're really focused around the goal of possible for Alzheimer's and dementia and other conditions that affect memory and thinking, and really connecting folks with resources and pushing the needle in terms of the science to better understand these different conditions.
Tell us about your present position. What is it you do? And I know at the University of California, but you're in a special area.
Yeah, so I'm an assistant professor at the University of California, San Francisco, and really in my current role, I wear 3 hats. So I basically participate in the clinical care of individuals who have concerns about thinking and memory, who have concerns about things like Alzheimer's. I participate also in research. So I'm particularly interested in disparities research and also biomarkers research. Disparity really has to do with unequal care between different groups of individuals. And biomarkers research really has to do with special tests that we have to better diagnose conditions like Alzheimer's disease. And so in my research, I'm trying to marry these two fields really and find the intersection between them. And then the third thing I do is really a lot of outreach to the community. So I spend quite a bit of time in the community raising awareness about Alzheimer's and dementia, giving lectures, trying to help connect folks to resources and care.
It's interesting, though, as you start to talk about this whole issue of dementia and memory. When I was growing up in my community, there's only one word, and that word was senility. And senility, I think, kind of captured everything we knew about memory. We thought that people would not have to, would all older people just stop memorizing things. So starting from there, let's discuss the differential diagnosis of senility. I know that's not a chapter in the textbook, but that's what we know.
Sure. Yeah, absolutely. I'm glad you bring up that point because it really is something crucial that we don't talk enough about. So one of the things that we've been trying to do as behavioral neurologists is really change the conversation and really change kind of the paradigm around what we consider to be normal aging. So for a very long time, as you mentioned, Dr. Mike, we have thought of aging as this process during which, oh, if I kind of lose my mental faculties, that's okay. It's just part of normal aging. We know that that's not the case. We know that as long as we are here and functioning, we should maintain some level of cognition such that we're able to take care of ourselves and do things for ourselves. And so we have to move away from this conversation, this idea of, well, mom or dad has a little bit of dementia. That's just normal for aging. That is not the case at all. And it's important to understand that because we're getting into a period of time where we understand a lot more about what actually causes some of these changes. As we get older, we understand a lot more about what causes cognition and thinking and memory to decline as we age. And furthermore, we're actually getting to the point where we actually have and are developing therapies. We're right on the cusp of some major discoveries with regards to therapeutics that may drastically change how changes in thinking and memory impact individuals as they get older. So we've got to change the conversation a bit around, accepting dementia as just part of normal aging to understanding, no, it's a disease, it's a condition, just like heart disease, just like kidney disease, that we can actually manage and do something about.
When we start talking about dementia, the two big dogs in the differential diagnosis are dementia and Alzheimer's. Tell us about the difference between the two.
Sure. So with the advancements that have been made in the science of understanding dementia, Alzheimer's, and other conditions that cause memory and thinking changes, have really come to understand that dementia itself is very different from Alzheimer's disease. So I'll try to explain it in a way that makes sense. Dementia just simply refers to a decline, meaning a change in memory, thinking, other abilities, such that somebody is no longer able to take care of themselves independently. That's all that dementia means, okay? In contrast to that, Alzheimer's actually refers to a process that is occurring in the brain itself. So in Alzheimer's disease, what you actually have is you have a buildup of two types of proteins in the brain, amyloid and tau. And they start to build up in inappropriate amounts. So you have a big buildup of these proteins, and we know they're not supposed to be in the brain in those amounts. Very often, people who have Alzheimer's develop dementia because having these proteins building up in the brain often leads to things like memory loss and changes in thinking. But again, trying to really emphasize the point that they're different, you can have Alzheimer's disease and not have dementia. I have a number of folks I take care of who have Alzheimer's disease in the brain. We've done the tests that have shown they have these proteins in the brain, but they don't have dementia. They're still driving. They're still actually working in some capacity. They're still doing a lot of things they need to do to take care of themselves independently. In contrast, there are folks I take care of who have dementia, but they do not have Alzheimer's disease. So they can no longer take care of themselves because their memory and their thinking has gotten very poor. But when we do the special test to look for Alzheimer's disease in the brain, they do not actually have presence of Alzheimer's disease. So again, really important to understand dementia, Alzheimer's, they're separate. Very often somebody who has Alzheimer's can develop dementia, but that doesn't always have to be the case. So we have to understand and think of them as separate, but there is a bit of a linkage and a bridge between them.
Well, tell us now, I know we've come a long way. It used to be an intuitive diagnosis, and you say somebody had it, and even when it was evolving, it was more intuitive, but now you have more accurate diagnostic tools. What are some of the things that you do beyond the obviously the history and to make the diagnosis of Alzheimer's?
Sure. So whenever we're considering a diagnosis of Alzheimer's or considering a condition that might be causing dementia in and of itself, there are a number of different tests that we like to do. So the first is just a good history and physical, sitting, talking with somebody, getting all the information and all of the story. the next step really are simple blood tests. So checking for things like thyroid level, vitamin B12 level, all of these different blood tests that actually can impact your thinking and your cognition. Once we start to get beyond that is when we start to get into a little bit more of our specialized testing. So we have things like the MRI, which are very good for showing us actually what the brain looks like from an overall structure standpoint, meaning has the brain shrunken in certain areas? Has there been a stroke in a very important part of the brain for memory? Beyond that, and this is really kind of where a lot of the cutting edge research is, we finally have tests that actually show us within the brain itself if there are Alzheimer's proteins present. So there are two ways that we do this currently. The first way is actually through a lumbar puncture. It's kind of like an epidural, except we're collecting a little bit of fluid as opposed to putting medicine in.
That's where you stick a needle in the spine to look at the spinal fluid, right?
Yeah, so we put a needle in the lower back into the epidural space, which allows us to collect a little bit of spinal fluid. And we can actually send that spinal fluid to the lab and look for Alzheimer's proteins. The other way that we look for Alzheimer's proteins is really quite fascinating. There are a special type of CAT scans called PET scans. We've developed actually these little molecules that we're able to inject. So you just inject them via an IV. They get into the brain. They actually bind to the Alzheimer's proteins. And then you can actually take a picture. You can take one of these PET scans and literally you can visualize within the brain where the Alzheimer's proteins are located. Now, that small kind of substance, obviously, that gets injected, it washes out of the system. It doesn't stay long term. But this really is quite, quite a novel kind of discovery for us and something we're really excited about because it gives us the opportunity to actually visualize Alzheimer's disease itself rather than just guessing about its presence in the brain.
We're talking with Dr. Charles Winden. He is a neurologist with a special interest in memory disorders, and we're talking about some of the things that are going on in the area of memory. We are so used to assuming that people get old, and what we're learning from Dr. Winden is that there's a lot of difference between various individuals who somewhat present with the same symptoms, and we've come a long way. Tell us a little bit about the management. I know that in the papers recently, there have been releases of some drugs to treat Alzheimer's. It's somewhat controversial as to what they are and whether they work or not, but I've been released by the FDA, so I assume they must have some impact.
Sure. So in terms of management, we really think of management in two different ways. So we think of pharmacological management, pharmacological just being a fancy term for kind of drug or medicine, and the second being non-pharmacological, non-medicine, non-drug. Just briefly on the non-medicine, non-drug, there are many things that we suggest, even in the absence of something like Alzheimer's, that are good for promoting your overall brain health. These include things like regular physical exercise and activity, eating right, making sure you're getting enough sleep. All of these things are really important to promote your overall brain health and promote your overall health as well. When we get to talking about the pharmacological type of treatment or the medicine and drug type of treatment, there are a couple of different options. So to date, vast majority of medicines, there's really two that have been approved by the FDA, but they really focus on symptom management. So there's a medicine by the name of Aricept. There's another medicine by the name of Namenda. Some folks may actually be familiar with these medications. They're very much used for symptom management. So they may help with a little bit of agitation, some mood disturbance. They may help with a little bit of memory as well, but you're not actually doing anything with the condition. So in the condition where somebody actually has Alzheimer's disease in the brain, giving them Aricept or Namenda may be helping symptoms, but the proteins in the brain are continuing to build up. The damage is continuing to be done. The newest therapies that have been introduced, and there's been controversy around Agikanumab, which is when they actually received FDA approval, but these medicines really get to actually removing Alzheimer's protein from the brain. So Agikanumab, the medicine that's been in the news that has a lot of controversy surrounding it, it actually gets rid of the amyloid protein in the brain. Most recently in the news, for folks who have been following along, there was a huge announcement about a new medicine called Canamab. It works in a similar fashion to Agikanumab. Again, it actually removes amyloid. It removes Alzheimer's pathology from the brain itself as opposed to just covering up symptoms. And the big difference with this medicine is that, per at least the company's announcement, it seems to make a meaningful difference in terms of cognition. So the folks who were on it seem to actually have a meaningful benefit with regards to function and memory function as well. And so many of us are anxiously awaiting the release of the actual data, which is to come a little bit later on this year, I believe in November, if I'm not mistaken. But I think these advancements really demonstrate that we're on the cusp of potentially game-changing therapies to come out in the field of Alzheimer's and dementia.
One of the things that I'm sure is a difficulty, and I think this is where you become a doctor as opposed to a physician, is dealing with families once they know they have a relative, well, dealing with the individual. Once they're starting to hear the diagnosis. I remember my mom had progressive loss of memory and confusion. And when I took her to the neurologist, she was very bitter about that trip, and I still remember that. But at the end of the day, our concerns were absolutely correct. So how do you deal with the individual, and how do you deal with the families?
Sure. So it's a bit of an art, I would say, in terms of really managing kind of the situation. So I want to impress, probably the most important thing to take away from this time together is that if you notice changes in memory, thinking, cognition, mood, other things, personality, behavior in a loved one, you must get help. You must talk with them. You must try to talk with a healthcare provider. Waiting and just hoping things go away is not the solution, particularly as we get into a new era where we may potentially have therapies that are effective for some of the conditions that cause these changes in thinking and memory. I would say that in terms of how to go about dealing with families, a lot of it has to do with kind of painting, the picture in terms of expectations and really convincing somebody from a non-kind of threatening standpoint or non-threatening manner that going to see the doctor to talk about their memory is actually a good thing. And I think, it's been a difficult conversation for a long period of time because there are a lot of structural issues with regards to our healthcare system. Many people have been mistreated in the healthcare system as well. Many people also, when it comes to memory and thinking conditions, don't have a lot of hope just because of what they've heard in the news. But you've got to try to push past those things and really just have open, honest conversations about, hey, I'm concerned. I've noticed some things. I really would like us to go and get this checked out. As your loved one, are you willing to hear me out? You've got to approach things, I think, in a very, non-threatening, very caring manner to be able to get your point across. Because the most important thing really is getting to the doctor to talk to somebody.
Well, I think it's interesting, though, that when you start to think about diseases like this and when you start to think about how they impact us, and when you talk about your office and one of your three interests being health equity, I must assume that for Black and brown people, there must be some differences.
Yeah, so this is really, I think, what has inspired me in terms of caring so much about health equity is I've seen firsthand within my own community. I was born and raised in Los Angeles, but I've seen firsthand within my own community issues related to health equity, how individuals who are from disadvantaged neighborhoods, individuals who are African American, individuals who are Latino, so often get the short end of the stick when it comes to our healthcare system. And the problem with this is that what you end up creating a situation and a condition where you get disproportionate amounts of disease and medical conditions among just certain individuals in certain groups. So for example, things like hypertension, diabetes, chronic kidney disease, you have disproportionate rates of a lot of those conditions among individuals who are African American, Latino, and socioeconomically disadvantaged, don't have a lot of access to finances and resources. And this is largely due to a lot of structural issues and systemic issues in our country and in our healthcare system. But as a physician who's also a citizen and a community member, I have a personal, issue with this in that it's not equitable care. We can't continue to allow these inequities to exist and just turn a blind eye to them. With regards to Alzheimer's and dementia, we're getting to a stage where if we have therapies introduced, a huge part of those therapies is going to be access. Who is going to actually be able to access these therapies? How are they going to be paid for? And how are we going to ensure that the inequalities and inequities that are present in so many other facets of our healthcare system are addressed when it comes to cognitive conditions, Alzheimer's and dementia?
And that feeds over into how important is it for us to be engaged as African Americans and Blacks in clinical trials for these drugs. I mean, obviously, we've seen a number of instances through the years where medicines were released, and because there were not enough African Americans in the study, some of the idiosyncrasies of those drugs was not appreciated. How important is it in this area?
Sure. So with regards to involvement in clinical trials and research, so I want to first just point out that there are two really big arms to research. So there is what is called observational research, and there is what is called clinical trial research. Both are equally important. We do at my institution, we do a lot of observational research. Observational meaning there are no sort of experimental medications or new or therapies that are being administered. It's just like going to the doctor's visit. So as part of an observational research trial, you would go basically spend time with a neurologist like myself, an hour, hour and a half, just talking. We would take some blood, do some blood tests, we would do an examination, and then you would get something like an MRI or a PET scan if you so chose, without any cost to you. That is very different from a clinical trial. In a clinical trial, you're signing up for a new therapy that may actually be beneficial that we're still learning about. Much of our research, not only in the field of aging and dementia, but in other specialties as well, has really been, I would say, limited by the fact that we don't have representative, our cohorts, the individuals participating in clinical trials, they're not representative of our population at large. Too often, they're lacking representation from African American, Latino, and other individuals who have been historically actually excluded from a lot of this research. But moving forward, to be able to really have medicines that are generalizable, meaning they are applicable to the greatest number of folks in our country, we need representation of all groups, of all individuals in these different clinical trials and in observational research as well.
Dr. Wyndon, you minimize the difficulty and the intensity of doing the work that you do with memory and dealing with people and families. What do you like most about what you're doing?
Sure. So I would say that I think for me, the most rewarding aspect of what I do is just the personal connection with individuals. To be able to be introduced to somebody, their family, their loved ones, grandkids, siblings, parents in some very rare instances, to be introduced to this individual and their entire family and support network in a very, very intimate setting. Unfortunately, oftentimes it's around, the topic of potentially a condition that's causing memory and thinking loss, but to be introduced to an individual on that level of intimacy really has been quite rewarding and really something that I cherish more than I think anything. And it's the opportunity to be in somebody's corner, really kind of fighting for them and trying to help them in one of the most special ways that I can imagine and think of. And so for me, that personally is a lot of what inspires me to get up every day to do what I do. It's that connection with people.
Well, Dr. Wyndon, thank you so much for taking the time to join us. Obviously, there's a lot of going on in this area. It's an area that was neglected for a very long time. And we appreciate not only your commitment to the science of it and to the clinical medicine involved in it, but your commitment to assuring that people of color and the underserved, who are so often left out of these drugs and these latest treatments, I have a bone to pick with the whole scientific community, because I believe that chronic disease in African Americans, Blacks, and Latinos is much because of how they're treated and how they often don't get to a memory center or an aging center and don't get the best care. Under these circumstances, with you in the mix, that's not going to happen. Thank you so much for joining us. And once again, we welcome you back to the Welcome Watch.
Thank you, Dr. Mike.